That's it, yes.
Okay.
Sorry, you have to start again then.
So we'll start again. So we started to speak about diabetic ketoacidosis, and I told you about this British Society of Pediatric Endocrinology and Diabetes. It's a good site that you could go through the guidelines if you are in a remote area or in one of these one of the DH hospitals.
Yeah.
Then this will be a good, very good. Just only you need an internet, and then you'll have the guidelines in front of you. So you said your understanding of the DKA is what? Diabetes, hyperglycemia, and
poor control, so ketoacidosis, secondary to that.
Okay. So can you remember the insulin action in the body from physiology?
Yeah, so acts to make sure that the glucose is managed, so that the glucose doesn't stay in the bloodstream, so it's taken up by the cells appropriately.
Yeah, so it helps to move the glucose from outside the cells to inside the cells. And also, when you have the glucose, it helps, especially the liver cells, to change the glucose to glycogen. And this is very important, especially in stress conditions, when you don't have enough insulin. Then you can have some storage which could be used in the stress conditions. Also, the insulin works in different ways. It prevents ketosis, which is the breakdown of the fatty acids, and which prevents also ketone body formation. So this is an important thing. And also, one of the things that insulin does is facilitate moving the potassium from outside the cells to inside the cells. So these are the three major things that we think about in diabetic ketoacidosis. Did you meet any patients with DKA before?
Not any pediatric patients that I've seen yet.
Okay. So usually, if we put a scenario, the last case I've seen was 10 years old, non-diabetic, poorly controlled, came with DKA, and he came to the A&E. They told you this patient is not diabetic, and he came to the A&E with very high blood sugars, for example 30 millimole. What is your approach in mind?
So ABC approach.
That's great. That's good.
And then kind of from there, if that's all stable, then kind of managing the DKA as per the King's guidelines. So I'd have a look at the King's guidelines and then kind of take it from there. So I haven't done it in pediatrics, but usually it's similar to adults with a sliding scale.
Okay. What usually you do if you had a patient and they told you that this patient is DKA, the most important, you have to tell your senior, who's the registrar, that this patient is coming with DKA, because it differs according to what is the situation of the child. If he's in need to be in general peds ward or to go to high dependence unit. So when he comes, the airway is very important, because sometimes they come with decreased conscious level, and also at the same time due to the DKA itself or due to infection or what triggered the DKA. And also sometimes the breathing, you could smell the acidotic, the acetone smell. Have you smelled this in the adult patient?
Yeah, not often.
Not often.
Yeah.
So there will be breathing very deep breath, and also at the same time it could be quick, so that they try to get rid of the acidosis by trying to wash out CO2 and try to do some respiratory alkalosis to compensate the acidosis, the metabolic acidosis. So airway, breathing, circulation. What is important in circulation in the DKA?
Blood pressure, heart rate, whether they're shut down.
Yeah.
Fluids.
Very frequent they come shut down. They could come very shocked, but also in the DKA, the management of the fluid is different, because usually the management of the fluid, you need to prevent the shock, but also you need to manage the fluids in a very careful way, because if you give like a very big amount of fluid.
Move that thing.
Okay.
Okay. So when you give the fluids, there is very important thing. If you felt that the patient is like just drying the lips, just you're thinking that he's dry, not maybe he's mildly dehydrated, and you calculate the dehydration 3%, like 3% only dehydration. And if you felt that the patient is shocked